morning, everyone. I'll be speaking on imaging in oral cancers. So briefly, first I'll be dealing with the relevant imaging anatomy because that helps in further delineating diseases better. And from there on, we'll look at some cases which will give us a better comprehensive understanding of what we have discussed. So imaging improves the accuracy of staging and aids in choice of treatment modalities. It plays an important role in loco-regional staging, distant metastatic workup, as well as post-treatment follow-up. So we'll begin with the anatomy of the oral cavity. Now, oral cavity is divided into two parts. One is the oral cavity proper, and the other is the oral vestibule. So everything that comes medial to the alveolar ridge is considered as oral cavity proper. This area is usually preferred to be imaged by MRI because of the high soft tissue contrast provided in this region. The oral vestibule is used, the modality of choice for oral vestibule is CT. So we'll start off with the anatomy of the oral vestibule. So everything that comes medial to the lateral to the alveolar ridge forms the oral vestibule. So in CT scan, the most important thing that we have to keep in mind in such cases is we have to use the technique called the puff cheek technique, because that provides a gap between the It provides a gap between the soft tissue and the high density alveolar ridges and teeth and reduces the artifact, and even smaller lesions can be seen, as well as the true extent of larger lesions can be estimated. So a brief about the anatomy, I'll just talk about the spaces and certain important areas that we are able to see in this. This is axial image. This is coronal reformatted images. So here we can see that this is the buccal mucosa region surrounded by the soft tissue that is the buccinator muscle. So lesions here can involve the buccal mucosa buccinator complex. This is the buccal space. So this has predominantly the buccal fat pad, which is hypointense. Fat is always hypointense on CT scan. It is lined by the zygomaticus muscle, the buccinator muscle, and posteriorly, this is the masseter muscle. Distal part of the parotid duct is also seen within this buccal space. Second important landmark in this region is the retromolar trigone. I'll talk about it in some time. In coronal, what we have to see is the gingivobuccal sulcus. So the principle in head neck imaging is one, whenever you, or in any cross-sectional imaging for that matter, if you want to see any organ, the preferable mode of seeing that organ is the cross-section or perpendicular sections of that organ. So when upper and lower GBS are more on the axial plane, so we will have sections which are perpendicular to it, so that is coronal, and then we can see the anatomy well. Second principle is symmetry. We always have to see symmetry on the right and the left side. So here we can see that in puff cheek, we can see that the buccal mucosa is symmetrical here on the right as well as on the left. Any asymmetry then points towards towards the presence of a lesion. So gingivobuccal sulcus is the region here. Upper GBS is in this region and the lower GBS is in this region. So that is the junction between the buccal mucosa and the gingiva. This is an MR image to emphasize on the fact that the soft tissue contrast provided by MRI is extremely high. First, I'll tell you which sequence this is. This is T1 weighted sequence. We can see that this is the spinal canal, vertebral canal, and this is the spinal cord surrounded by CSF, which is hypointense. So that is a sign when fluid is hypointense, it is T1 weighted image. And anatomy is always seen on T1 weighted images. Again, the buccinator muscle. So the buccal mucosa is here. This is the buccinator muscle. We can see it communicating with the superior constrictor muscle through the RMT, tonsils. We'll see this anatomy better next. So as I said, puff cheek technique. So these are the cross-sectional images of the same patient. This is non-puff cheek. We can see the alveolar ridge. We can see soft tissue lateral to it. We cannot be sure if there is a lesion here. Clinically, there definitely is a lesion which can be easily seen, but on imaging, we may not report this. And on puffed cheek, what we can see is the lesion is popping out here. So small lesion in the left buccal mucosa is very well seen on the puffed cheek technique. So this is the importance of puffed cheek. Another important thing in oral imaging, oral cavity imaging is bone window images. So we always see soft tissue images along with bone window reconstruct, because in soft tissue, subtle bony erosions cannot be well appreciated. So once we are sure about the presence of the lesion, then we also correspond that sequence on bone window reconstructs, and we see if there is any adjacent subtle cortical erosions or major cortical erosions. Again, this is the same patient that we just saw. These are the coronal reformats. As I said, symmetry. Symmetry on the right and the left side. We can see that the curvature here is slightly effaced here. So the buccal mucosa, there is also soft tissue thickening here, which is enhancing on the left compared to the right. So normal soft tissue also enhances. A normal muscle will also enhance, but neoplastic lesions will have this heterogeneous enhancement, which can be easily appreciated. So there's a lesion in the left buccal mucosa and it is also extending to the upper GPS. And bone windows, we can see that the cortices are well maintained, so there's no bone erosion. So the retromolar trigone. Retromolar trigone is a important region. Firstly, because lesions in this region, smaller lesions can be easily missed. Secondly, because of its spatial relationship with other structures. So it is a triangular shaped mucosal fold which is seen behind the last mandibular molar, and it is extending superiorly with the apex behind the last maxillary molar. On imaging, we can see it as this soft tissue area which is symmetrical on both sides with some amount of fat density within. When there is thickening, asymmetry, or enhancement, we have to suspect that there is a lesion here. Also, there will be clinical information that will suggest that there is some RMT lesion. So we have to be careful. Important thing in RMT lesions is that these lesions have a propensity for bone erosion. So always we have to, once we detect a lesion, either in the RMT or extending into the RMT, then we have to see bone window adjacent to it to look for erosions. Now the spatial relationship of RMT. So it has such a relationship that an RMT lesion can spread in various directions. So anteriorly, we can see that it can spread along the alveolar ridge. Posteriorly, it can also spread along the inferior alveolar nerve. From there on, it can have a superior extension and perineural spread. Laterally, it can involve the adipose tissue of the buccal space. It can further go posteriorly into the masseter and the masticator space. Medially, this is the tongue and the tonsils. So it can involve the tongue as well as the tonsils. Also, an important structure in the retromolar trigone region is the pterygomandibular raphe. It is not seen on any imaging modality, but we know that the superior constrictor, and we saw it on MRI, and the buccinator muscle, the pterygomandibular raphe will be present. If there is spread along the pterygomandibular raphe, the lesion can go superiorly into the medial pterygoid plates. Inferiorly, it can also involve the mylohyoid and the floor of the mouth. So again, in retromolar trigone, there is another reformat that we use. This is a pure axial image. There are certain reformats or post-processings that we can do in CT scans or MRIs. And we can have certain oblique sections to exactly delineate certain areas. So this is an axial section. If I align along it, we can get an oblique sagittal section. This is not a true sagittal section. And in that, I can appreciate the retromolar trigone region very well. Again, any asymmetry here, we can compare it with the other side. Any asymmetry here, any soft tissue lesion, any effacement of the fat in this region, along with this bone, any cortical erosion in this bone can help us suspect lesions here. So next I'll talk about intratemporal fossa and pterygopalatine fossa, because buccal mucosa lesions can, in advanced stages, spread in these regions. Even advanced tongue cancers can spread here. So I'll briefly touch upon that. This is an recent article by Dr. Suprita Arya that has tried to correlate the surgical as well as radiological anatomy and give a comprehensive understanding of the intratemporal fossa. So these are 3D reformats, and we can appreciate the infratemporal fossa region as well as the masticator space. I'll show that on CT scan. So these are coronal and axial images in the region of ITF and masticator space. So masticator space is a fascia lined space. So it has a inverted pyramid structure with base lying along the skull base. The contents of the masticator space are the masseter muscle, the vertical ramus of the mandible, and the two pterygoids. So this is the lateral pterygoid, and this is the medial pterygoid. While the infratemporal fossa, the difference between the masticator space and infratemporal fossa, the exact anatomy and the exact extent, because it is a non-fascia line space, is a little bit controversial. But for practical purposes, it is considered as the space medial to the vertical ramus of the mandible. So the ramus of the mandible and the masseter are not included in infratemporal fossa. What is included in the parapharyngeal region? So this is the pharynx. We can see this fat containing area, which is the parapharyngeal fat. So that is a part of infratemporal fossa. It is not a part of the masticator space. On axial, we can see the extent of the infratemporal fossa. Again, the masticator space, purely the masticator muscles, medial pterygoid, ramus of the mandible, masseter. Infratemporal fossa, anteriorly, it is extending from the posterior part of the maxillary sinus. So this fat containing area is the retroantral fat, which also is a part of infratemporal fossa, but it is not a part of the masticator space. Posteriorly, we can see the medial pterygoid, parapharyngeal fat again. Posteriorly, it extends to the mastoid temporal bone. Roof is the greater wing, and anteriorly, the posterior part of the maxillary sinus. This is a section which is higher up, again showing the infratemporal fossa. This I'm showing to show the difference because ITF is divided into high ITF and low ITF. The reason for this is high ITF lesions come almost close to within 1 centimeters of skull base. So when lesions are extending here, they can be associated with poorer prognosis. So how do we identify high ITF when we have pure axial sections? So we can see the coronoid process and the condyle. The mandible is continuous here. The moment we see a defect here, which means that we have crossed the notch. So anything above that forms a part of high ITF. Another thing that we have to know here is, so this is the lateral pterygoid. Even in high ITF, there is a slight distinction when there are lesions which are more anterior, like involving the retroantral fat. Even if they are high ITF, they can still be amenable to surgery. When they start involving the pterygopalatine fossa or the pterygomandibular fissure, then they are considered at high ITF and they have worse prognosis. A little about pterygopalatine fossa. Now, the best imaging technique for viewing the pterygopalatine fossa is high resolution CT images with various oblique reconstructions. So I'll show the pterygopalatine fossa in this sagittal reconstruct. We can see the greater palatine foramen here. So this defect is the greater palatine foramen. I go higher up along this canal, that is the greater palatine canal, and this teardrop shaped structure, fat containing area, is the pterygopalatine fossa. Lesions, when we see any upper alveolus lesion, which we are probably involving the greater palatine foramens, we have to look higher up to see if it is spreading higher up and then going into the intracranial compartments. So on axial, I'll show the greater palatine foramen. So this is the maxillary sinus, this is the nasal cavity. This bony structure is the hard palate. So these two symmetrical triangular structures are the greater palatine foramen. So we'll again see that in coronal. When we see some lesion extending here or absence of the appearance of a normal structure also means that that structure is involved. So when we don't see that structure, then we'll have reformats. We'll look into the pterygopalatine fossa and higher up. This is the axial anatomy. So this is the maxillary sinus. These are the pterygoid plates. Medial pterygoid plate, lateral pterygoid plate. This is the pterygomandibular fissure. Pterygomaxillary fissure. I'm going further higher up. So again, I'm in the pterygopalatine fossa region. We can see this vertical canal on both sides. So that is the communication of the pterygopalatine fossa with the Vidian canal. So first, when we go slightly higher up, we see the Vidian canal. I'll go further higher up. I can see the pterygopalatine fossa. Laterally, it is communicating with the inferior orbital fissure and then the orbit. And medially, this vertical canal is the foramen rotundum, communicating with the middle cranial fossa. Just for completion's sake, I'll show how it looks on coronal. In bone window images, when we see these foramens and they are loaded, that means they are involved. But early involvement of the nerve is better appreciated on MRI because there'll be initial thickening and enhancement, which will not cause any bone erosions. So the superior and lateral is the rotundum, medial and inferior is the Vidian canal. Also, I'll show the foramen ovale, which we can see here. This is the skull base. We can see the symmetrical defects along this side. These are the foramen ovales. On axial, we can see the foramen ovale in this region. This is the bigger oval foramen, which is the foramen ovale. And just behind that, the smaller foramen is the foramen spinosum. This appearance is linked to that of the bottom of the stiletto. So the sole is that considered of the ovale, and the spike of the stiletto is that of the foramen spinosum. So we have to keep this anatomy in mind, and whenever this is distorted, it means there is involvement. So by far we have spoken about the buccal mucosa. Just a checklist that when you're seeing a scan, what all do you want to see? To see if the scan first is adequate. There's puff cheek, there is all the sequences that are available. From there on, we can comment on the locoregional extent, where all it is, this local size and where all it is extending. Second is bone erosion. CT is the modality of choice. If we are suspecting any marrow invasion, then we may need an adjunct MRI. Perineural invasion. When we are suspecting perineural invasion, especially in buccal mucosa, there are two types. One is along the maxilla. If the lesions there, we'll see V2 division. If it is along the mandible, we have to see the V3 division. So in those cases, we can use MRI. And next is nodal metastasis. So the best modality to look for nodal metastasis, which we routinely do here, is ultrasound with or without FNAC. That has been discussed in detail by sir in the earlier lecture, so we won't talk much about that. So we dealt with the oral cavity and associated anatomy involving the RMT, infratemporal fossa and pterygopalatine fossa. Now we'll talk about the oral cavity proper. Predominant organ in the oral cavity proper is the tongue. So we'll mainly talk about tongue anatomy and also the floor of the mouth. So first we'll look at the extent of the oral cavity. On imaging, how do we decide what is oral cavity and what is oropharynx? Where does one end and where does the second begin? This is the anatomical image, so we can easily correlate on a sagittal teat-weighted image. So this is the hard palate that we can see here. This is the soft palate. Now the junction between the hard palate and soft palate, we draw this line along the junction between the C1 and C2 vertebra. And we connect that at the junction of the hard and the soft palate. The next line is drawn along either the valleculae or the hyoid. We can draw anywhere. And the vertical line which joins these 2 points, that is the junction of the hard and the soft palate and the vallecula or the hyoid, can divide the oral cavity or tongue into the anterior and the base of the tongue. The true anatomically, we can see that the circumvallate papillae divides it into the anterior and this, but circumvallate papillae is not seen on MRI. So we can use these indirect landmarks and then decide the exact epicenter of any lesion. So the boundaries. Again, this is T1 weighted image. We always see anatomy on T1 weighted images because it gives high contrast. The fat interspersed between muscles and structures gives us a good contrast to define each and every structure. So anteriorly, it has the lips. Posteriorly, lateral boundary is the gingivo-buccal region and the cheek. So posterolaterally, we can see the tonsillar, anterior tonsillar. So these are the anterior tonsillar pillars. Again, these are not very well seen on imaging, but we can have an estimate that these are the symmetrical tonsils. So anterior to it, we can see that this is the tonsillar area. Again, anterior tonsil pair. Again, this is the buccinator RMT region. So pterygomandibular raphe will be here, and the superior constrictor muscle going posteriorly. Posteriorly, again, there's the circumvallate papillae. So what we can do on imaging is we again on axial. So I said the landmark between the anterior and posterior on sagittal. On axial, we can have a rough line along the last molars. Anything posterior to it forms the base of the tongue. Anything anterior to it is anterior to the third of the tongue. On sagittal, I'll complete the rest of the boundaries. One is along the junction of the hard and the soft palate. Posteriorly, again, the circumvallate papillae and the dorsum of the tongue. Inferiorly, there's the valleculae and the hyoid. So valleculae, hyoid, and the floor of the mouth form the inferior border. The floor of the mouth, I'll let you know about the anatomy later on. So it includes the floor of the mouth as well as the mandibular alveolar ridge. This forms the inferior margins and boundaries. So oral cavity proper imaging, or more so tongue imaging. So anatomy of tongue is well demonstrated on MRI. On axial T1 weighted images, fat with its high signal intensity can be seen interspersed between the muscles of intermediate signal intensity. So this is a CT image. We can still see muscles and certain anatomies on CT, but obviously the high contrast in MRI helps for exact size and delineation of lesion, because smaller extents can also have a greater impact on the staging of the cancer. So the abnormal signals seen on MRI are well correlated with pathological findings. Certain anatomies best appreciated. So as I said, any organ we want to visualize, we'll take perpendicular sections through it. So we have multiple complex areas in the oral cavity proper, or oral cavity altogether. So floor of mouth and hyoid, we'll always see in coronal, better appreciated on coronal images. Valleculae, we can well see on axial images. We always correlate with one more sequence, one more section, but these are the sections where we can best appreciate the involvement. Base of the tongue and pharyngeal infiltration and the exact length of a lesion, especially in the oropharynx, will be best seen on sagittal images. Again, if there's cortical bone involvement and there is any suspect of subtle erosion, then we can do an adjunct CT. So imaging anatomy of tongue. Since we use MRI, I will first briefly speak about the sequences, just a summary on which is what sequence. So this is T1 weighted, T2 weighted, T1 post contrast, stir images. These are the major sequences that we use in tongue imaging. Now T1 weighted, we can see CSF is hypointense. T2, CSF is hyper. Stir, CSF is hyper. And again, T1 post contrast, CSF is hypo. So I have established that these are T1 sequences. Next, if I want to see why this is a contrast and this is not a stir sequence, so there is contrast in the vessels. I can see IGV and carotid, which are filled with contrast. And the fat is completely suppressed. So this is T1 post contrast fat sat image. Okay. Why is this stir image? So this is stir is a type of T2 image. So firstly, the CSF is hyper. Second, all the fat is suppressed. So this is a stir image, which is mainly used to highlight the lesion. Any edema, any inflammation, any pathology will become hyper on stir images. It will also be hyper on T2, but the fat, which is also hyper on T2, may sometimes obscure smaller lesions. Now moving on to tongue anatomy. So I will talk about axial in certain important sections, and then we'll talk about the coronal anatomy. This is the axial section at a higher level. This is the tongue proper. Centrally, we can see the fatty lingual septum. So because of fat, it is hyper. Fat is always hyper on T1, and any lesion is always hypo on T2. Next, we can also see again buccinator, superior constrictor, tonsils. These are the tonsils are slightly hyper on imaging. Yeah, and then the extension between the anterior and posterior tongue I have already discussed. Next is a section which is a little lower down along the floor of the mouth. So what all muscles do we see here? These are the paired genioglossus muscle. And this blob of muscular tissue here, which can be seen here, are the intrinsic muscles. So here also, when region, and I still want to differentiate where am I on the anterior and the posterior section. So when the paired genioglossus become obscured and the intrinsic muscles are seen, that becomes the anterior and posterior tongue. These are the hyoglossus, paired hyoglossus muscle, important because we can trace the lingual vascular bundle along these. This is the mylohyoid. We can see here the mylohyoid sling. Same way, this is the mylohyoid sling. And lastly, the sublingual and the submandibular gland. They also have fatty tissue within them. So they will also have slight hyperintense signal. That is why muscles are hypo, but they have hyperintense signal. And so this is a sublingual region and this is a submandibular region. One more point to note is the marrow. So on T1 weighted images, any marrow in any bone will appear hyper. So T1 images are the best to see marrow involvement. So whenever we are thinking that there is some marrow invasion, we can go back to the primary T1. It will give us the exact extent of the marrow involvement, because a contrast image or a stir image might show additional edema also, and we may overestimate the involvement. This is further down. This I have put to just show the anatomy of the vallecula. I said the vallecula we'll see in axial sections. We can see these paired air-filled structures. This is the epiglottis. This is the glossoepiglottic fold. So when these are effaced, we see soft tissue around it, and these are, one of them is effaced or both are effaced for that matter. That means they are involved. So next is coronal sections. In coronal sections, what we see, we can delineate the floor of the mouth. So roughly what we can either do is, this is the mylohyoid sling. So either everything within this cup forms the floor of the mouth, or we can draw a line along the superior cortices of the mandible. Anything below it forms the floor of the mouth. What muscles can we see here? So the central fatty lingual septum. This is the genioglossus, paired vertical genioglossus, geniohyoid. And below these muscles are the anterior belly of the digastric. This is the cup, which we can like a representation to show that all this under this is the floor of the mouth. On sagittal, I'll just show this important anatomy. So this fan-shaped structure is the genioglossus muscle. Superiorly, these are the intrinsic muscles. This hypointense band is the geniohyoid. Inferiorly, the further thinner band between the mandible and the hyoid bone is the mylohyoid. Again, hyoid, we are going to always see, preferably see in coronal. So we'll try to locate the hyoid on sagittal. And then because it is an axial organ, so we'll like to have perpendicular sections, that will be coronal sections. So on T1, this is the hyoid on sagittal, and here we can see the hyoid. So whenever we see any lesion reaching up to here, or this hypointense cortex is disrupted, or we cannot see the hyoid altogether, it means the hyoid is involved. I'm going further posteriorly so I can see the two horns of the hyoid. So this was all about the anatomy. Again, in imaging check, size, the thickness, the depth of invasion. We have to see if the lesion is crossing the midline, if the adjacent structures are involved, floor of the mouth, base of the tongue is involved. We have to see bone invasion, neuromuscular bundle and perineural spread, and lymph node metastasis. So this was all about the relevant imaging anatomy. Now we'll see certain cases, some CT cases and some MRI cases. We'll start off with straightforward cases and then build up on little complicated ones. This is the first. So I've kept a small quiz towards the end for the fellows. So if they get an idea right now, then they might be able to do the quiz a little better. So this is a straightforward case. Puff cheek technique, soft tissue window, bone window, and axial imaging. Asymmetry along the right buccal mucosa extending into the inferior GBS. No bony erosion. On axial, I can see buccal mucosa buccinator complex involved. So this is early buccal mucosa cancer. Second, so this is inferior alveolar lesion, extensive bony erosion. I'm going further superiorly. This is the normal masseter. I said we have to see symmetry on both sides. If we have any doubt, normal masseter on the right side. So on the left, the masseter is involved. There is enhancing tissue there is fat stranding. So there is masticator space involvement in this case. Again, coronal reconstructs, we can see the inferior alveolus, this paramandibular soft tissue, it is extending up to the skin, in fact. And the mandible is completely eroded. A point to notice, when we want to see inferior alveolar nerve, what we can do or we should do is use oblique sagittal images. So we can see the complete course of the inferior alveolar nerve. In this case, obviously, this is extensive disease, and we know that there's complete erosion. So in that part, there is involvement. But when there are subtle erosions or only superficial erosions, and we want to be sure that the nerve is intact, sagittals, oblique sagittals will show us the entire course of the nerve, and then we can report that it is uninvolved. This patient then underwent hemimandibulectomy. Next case. So again, non-puff cheek, puff cheek. We can see this asymmetry on the left side compared to the right. We can see normal soft tissue, a little bit of fat. There is enhancing soft tissue in this region. So this is a subtle RMT lesion. In RMT, in coronal, we can appreciate the RMT lesion. In RMT, we have to be sure that there's no cortical erosion. This is the normal side, which is the right side. This is the abnormal reconstruct. So we can see cortical erosion here. So this is an RMT lesion, superficial bony erosion. And we can see these oblique sagittal images, how nicely the inferior alveolar nerve is appreciated. These are 3D reconstructs just to give an idea about the presence of erosion and the residual length, vertical length of the mandible. Actually, we can see the erosion. So this patient then underwent wide excision and marginal mandibulectomy. This is another interesting case. This is a lower alveolus lesion on the left side. So when we evaluated with CT, what we see is there is bony involvement. There is extension of the soft tissue going into the mandible. And when I'm going further posteriorly, almost the entire mandible is involved. There's thinning of the cortices on both sides. What I see on actual images, we can see this bony reconstruct. The lesion is going and involving, crossing the midline and almost the entire mandible. So a lesion which was initially only seen on lower alveolus, when we did a CT imaging, we realized that that was just the tip of the iceberg, and the true extent of the lesion is completely into the right side as well. So this patient will then need extensive mandibulectomy because of the extent of the lesion. These are again. We can see it. So bony reconstructs show us the exact delineation. I'm showing the reconstructs on sagittal also. We can see the exact anatomy and the exact extent of the lesion. So we don't need any further modality to delineate the size and extent of the tumor. This is the left side, which was more involved. We can see only this much of the alveolar canal. On right side, it was short of the angle. We can see that the inferior alveolar nerve is still intact in the posterior extent. This is the gross specimen. We can see that the tumor is on the left side and the entire mandible had to be removed. And we can see that this is the cut section where the tumor can be appreciated. So now, slightly complicated cases. This we can see on coronal reconstruct. There is an enhancing soft tissue lesion on the left side. So this is a floor of mouth lesion. It is also having paramandibular extension, involving the lower alveolus as well. There is erosion of the cortices. This is the floor of the mouth region. As I showed on MRI, these are the genioglossus, so lateral aspect of the tongue is also involved. Important in floor of mouth lesions, we have to see the distance from the hyoid bone. So as I said, hyoid bone, this is the hyoid horn, this is the central part of the hyoid bone, this is the axial extent. So we can see that the lesion is not abutting or involving or eroding the hyoid bone. So then the patient underwent surgery. Also the sagittal reconstruct showing the cortical erosion, which is just superficial. In such cases, we always have to also give the vertical height because that decides segmental mandibulectomy. So just quickly, we have seen a couple of cases on cortical erosions and the mandibular involvement. So if there is periosteum invasion or minor cortical erosion, we can do marginal mandibulectomy. So that becomes essential, which is when we also give the vertical length of the residual mandible. And this was the case that we saw RMT lesion. This underwent marginal mandibulectomy. When there is extension into the bone marrow or the nerve involvement, this is just the previous case. Here also we have decent vertical length, but there was paramandibular soft tissue extending the entire length of the mandible. So this patient underwent segmental mandibulectomy. Here we can see that there is upper alveolus lesion extending, eroding the inferior wall of the maxillary sinus and going into the right maxillary sinus. And medially, it is also involving the hard palate. These are the axial sections. We can see the tissue, soft tissue eroding the lateral wall and coming outside into the fat. Higher up, we can see that the retroantral fat, again, the symmetry. The retroantral fat is well maintained here. There is bony thinning of the bone and soft tissue in the retroantral fat. And just for representation, I showed the high ITF, that there's no high ITF involvement. Again, this is not tumor. This is tumor which is enhancing. Because inferior alveolar lesions usually are also associated with sinusitis because of the blockage of pathways. So this is just sinusitis. The exact extent is only so much. On sagittal, I can see that hyoid bone is not eroded. So that is an important information that we have to give on such cases. So this is the last CT case. Again, upper alveolus region eroding the inferior wall of the maxillary sinus, going into the maxillary sinus. There's some enhancing soft tissue also in the nasal cavity. Posteriorly, retroantral fat is involved. These are the pterygoid plates. So we can see the normal pterygoid plates here. The lateral pterygoid plate is eroded here. I cannot see it. Higher up, I'm supranotch ITF. There's soft tissue within the maxillary sinus and also in the retroantral fat region. So this is high ITF involvement. This is extensive disease. So patient went into NACT. So these were all my CT cases. Just for completion, I'll show you how metastatic nodes can be seen on CT. I will not talk about the levels because that will become very extensive. So this was a right BM lesion, and we can see this rounded structure with non-enhancing central areas, which is following the regions where we expect to see lymph nodes. So this is also abutting the platysma. In fact, this patient also had extranodal extension. This is the submandibular gland. So this is a right 1B metastatic lymph node. When we see the jugulodigastrics, then we see the carotid and the jugular, and then we see the lymph nodes along that and pick up abnormal lymph nodes. Now MRI cases. Again, we'll start off with straightforward cases. MRI tongue, as I have said, that we start off in coronal sections. We'll first take a T1 weighted image, we'll take STIR image and T1 post contrast. We'll try to look at where the lesion is. We can see a right lateral hypointensity. Lesion is always hypo on T1, fat is always hyper on T1. So there is asymmetry. Fat is well maintained here. It is hyperintense on STIR. It is enhancing on T1. So an early tongue cancer. No further extensions. So sagittal image just to show that there is no other extension of the lesion. Second, advanced tongue cancer. Left lateral wall, again T1, STIR, and T1 post contrast. So hypointensity on T1 extending up to the midline. This is the lingual septum. On STIR, I can see it is extending up to the midline. Enhancement also, it is correlating with the extension. So left lateral tongue lesion, no involvement of the floor of the mouth. Axial images, we can see that it is epicentered in the anterior tongue, but it is extending along the base of the tongue. But there was no vallecular involvement. There was no hyoid involvement. Sagittal section can show that it is only limited to the superior extent of the tongue. This also had metastatic nodes, very beautifully seen on ultrasound images. These are the metastatic nodes on MRI. So this patient underwent surgery. A point to note in this is the depth of invasion. So I'll just talk about depth of invasion, which is a microscopy finding. But there are papers now that have suggested that MRI correlates well with histopathology as far as depth of invasion is concerned. How do you measure depth of invasion? We draw a line along the interpreted mucosal surface. and we draw perpendicular along the maximum depth, we have to exclude anything which is outside because that forms the part of the tumor thickness. So here it was around 23 mm, and we can see the maximum depth on histopathology is 2.2 centimeters. This was a recent paper by Dr. Abhishek Mahajan. So that has correlated that has suggested imaging role in staging and how to see depth of invasion. And so they have illustrated that the difference between thickness and the depth of invasion. So you exclude the exophytic component. In case of an ulcerated lesion, you still use the mucosal line and use the depth of invasion. So the thickness will be lesser than depth of invasion. Recently it has started coming up that ultrasound is more accurate for depth of invasion. So because of its high resolution, especially in anterior tongue lesions. So this is a representative case that we have done here. The ideal way is you have to include the normal mucosa, draw a line along the normal mucosa, and then the maximum involvement is the depth of invasion. This was 3.6 mm. Reported depth of invasion was 0.3 mm, 0.3 centimeters. Just quickly on ENE, which is also a part of the new AJCC guidelines. So again, that is clinical and histopathological, but there are papers that are suggesting that we can predict radiological ENE. If there is a metastatic node and there are fuzzy boundaries, or the nodal mass is extending into the fat, or it is going into the muscle, then that becomes extranodal extension. Last two cases. So again, T1, T2, and T1 stir and T1 post contrast. Advanced tongue cancer, entire left tongue is involved. We can see this is the mylohyoid. Again, anatomy is best seen on T1. So sometimes when we are confused because if we demand stir on T1 post contrast, we can say on T1. So the hypointensity is extending up to mylohyoid. So floor of the mouth is involved. This section is to show sorry, this is also stir. This is not a post contrast image. This section is to posterior section to show the hyoid. So we can see this hyoid, hypointensity is maintained, marrow is seen, the lesion is reaching up to the hyoid here. These are further relations. We can see this is the normal side of the tongue, right side. This is the left completely involving the base of the tongue as well, reaching up to the hyoid. Floor of the mouth is involved. Posteriorly, here we can see the base of the tongue. Tonsil is involved. Lingual tonsillar sulcus is involved. And this is the valleculae section as I showed earlier. So this is the epiglottis. Valleculas are maintained, so it is not effaced. So valleculae are not involved. This is a section just to show the hyoid. So the lesion is extending up to the hyoid. Axial section, we can see the marrow in the hyoid. It is appearing fine though. Last case, extensive disease involving the tongue. Hypointensity, mylohyoid is not well seen. Digastrics are not seen. On enhancement, we can see the lesion extending beyond the mandible as well. Base of the tongue is involved. Tonsil is involved. Now here what we are going to see is this is a slightly higher up section. So this is the masticator space normal on the right side. We can see there's enhancing tissue in the masticator space here. So the medial pterygoid is involved. The marrow and the mandible is eroded and masseter is also involved. So there is low ITF involvement in this case. The anatomy is completely distorted. So lower down when I'm seeing that the valleculae is also effaced. So valleculae are also involved. So higher up there is my low ITF involvement. Lower down it is reaching up to the hyoid. It is involving the valleculae. So high ITF is uninvolved. Again, this is the sagittal extent. On sagittal images, we'll see the epiglottis. So the normal appearance of the epiglottis is slightly more curved. There is enhancing soft tissue involving the mid portion of the epiglottis as well. So there is some involvement of the epiglottis too. High ITF sections, no involvement. An important point is this, as I said, marrow involvement. So we can see T1, we can see marrow on the right side, which is replaced by soft tissue on the left side. So that is how we note marrow involvement. Enhancement is extending up to the midline, but the true extent of the lesion is short of midline on the left side. This is more important in smaller lesions. When this is an extensive disease, but when there's a smaller lesion, it becomes more important. We have to carefully see T1 and post contrast. Just a note on additional images. I already said that ultrasound neck with guided FNAC is high sensitivity for nodal mets. PET-CT can be avoided in all, may not be needed in all cases. Only in cases where we are suspecting distant metastasis or advanced malignancies, we can use PET-CT. And also for post-treatment follow-up, we also use something called as NIRADS for post-treatment follow-up, which is again very extensive, so not going to be spoken here. And lastly, CT-guided biopsies in difficult cases. Sometimes there are certain cases which become like huge dilemmas. In such cases, we can try CT-guided biopsies and reach a diagnosis. So this was an interesting case. She was operated for buccal mucosa lesion. After a few years, she came back with lesion along the left mandibular region. The scans were reporting or appearing as either they are radionecrosis or recurrence. We are not really sure. So, and this is a very difficult region to reach, but on CT-guided biopsy, then we can provide material. It provided material. It was seen that this was recurrence and the patient underwent surgery. So this was all about imaging and oral cancers. Now I have a couple of cases that maybe the fellows can try if they're straightforward cases, just 3-4 cases. So whoever wants to try, Anshu wants to try.
Yes. So there is a lesion seen on the right side of maxilla. It is eroding palate, involving the right side lateral nasal cavity, lower down, and
I'll show the next sections here.
it is involving palate. Pterygoid plates are normal. Close to the posterolateral wall of maxillary sinus.
So ITF involvement is there?
No ITF involvement. There's some soft tissue into the retromaxillary area.
Yeah. So there is little erosion here and there is soft tissue in the, I said symmetry, fat as well here. So low ITF, small early disease. Yeah. It's good. This is the next case, simple case again.
There's a right side lateral tongue lesion.
What sequences are these?
First is T1.
Yes.
Second is TER.
Yes.
Third is post contrast. T2.
T1.
Post contrast.
And any extensions of the lesion?
None is not the right lateral tongue. Just the floor of mouth is free.
Yeah. Early.
Early. Extensive tongue lesions.
Yes, Neither.
This is an extensive tongue bleeding, sir. It is involving the floor of mouth. I think at the center is right lateral border of the tongue. And cross the midline, going to the opposite side, floor of mouth is involved. It's going on with the
Both sides floor of mouth.
both sides floor of mouth.
So again, I'll highlight one important point here. So because I suspected that, we can get confused about the floor of mouth lesion. So this is a right lateral tongue lesion. It is definitely crossing the midline. It is abutting the mylohyoid on the right side. It is not involving the mylohyoid on the left side. Why? Because this is post contrast. So T1 is very helpful in such cases. I had mentioned that sublingual region or sublingual fat also will be hyper intense, and on post contrast, it will enhance. So this is actually normal sublingual gland, which can be overestimated as lesion. And then we can say a small lesion is reaching up to the floor of the mouth while it is a normal gland. So we have to compare it with the T1. There is no soft tissue in this region. There is some involvement of sublingual region on the right side. And posterior sections, I can see that the mylohyoid is involved on the right, but left is free. So in this, maybe it may not matter, but in early cases when there's just a right lateral lesion abutting the sublingual gland, we cannot say that it is reaching up to the floor of the mouth. So we can see a associated plain T1 scan to be sure about it. The further relationships, you can tell me like what areas are involved. So in this section, where all is the extension of the lesion?
It's going posteriorly into the tonsil because at the posterior activity is going on. And veins of tongue is involved.
Yeah.
Same shape.
Yeah. Ton.
The dots.
Hmm.
Tonsils are involved and so is the basic.
And here? Hmm. And here?
Up to the vellicula.
Right vallecula is
Right.
effaced. What about the hyoid? So the lesion is, I will have to correlate in, it is just reaching the hyoid. It is not eroding the hyoid. Last case.
It is a lesion of the upper alveolus.
MRI.
Yeah. Sorry. The anterior tongue is involved. It is
Okay, so
mandible is free.
tell me the sequences. This is PSF is
Hyper. So that is
T2.
T2 sequence. Second is third image
This is also T2.
of CSF is again hyper.
This
This
is
is contrast.
T1 post contrast. So now,
So it is anterior tongue lesion. It is crossing midline. And it is mandible is free.
I'll show the next sequences.
Here is,
T1,
yeah, it is Steven.
store and post
Stern
contrast.
post contrast. And here again, here we can see mandible. Mandible might be involved. That's the cortex. It is reaching the cortex. Floor of the mouth is. Floor is.
So this is, so this is normal study. There is no lesion here. This is a post-treatment flap. I have said that fat is always hyper intense on T1, right? So if there is a lesion, it has to be hypo intense. There is no enhancement. Tongue lesions always enhance intensely. There's no enhancement on post-contrast images. This is T2. Again, we can see the flap here. There is hypo-intense line demarcating it, and there is no lesion here. So this is post-treatment follow-up scan with a normal flap, no lesion, no recurrence. This is for post-treatment scans. So this is it. Thank you.
Very well done. It is very well.
Thank you, sir.
Hear more of these. Cases.
Yes.
Nice to listen to you. Think and interpret.
Yeah.
Very nice. Next time we should do diets and try. Use it science.
Done.
The three main groups.
Yeah.
Very well. Very nice.
This also point to MR supervision. Cases. Actually, that MR is second. Important. That
More and more realization will be needed in environments. Typically for the tongue cases.
Yeah.
And for the scum cases.
Yeah.
What situations in larynx that are not complement the CT scan?
So only when we want to see marrow involvement. So cartilage involvement, again, subtle erosions, we can see on CT. But when there is marrow involvement, in those cases, then we need an adjunct MRI. Otherwise, CT is the modality of choice because that region, there is a lot of motion. We can see it better on CT and most of the contrast can be well appreciated.
So some of the CT guided biopsies that become necessary
Yeah.
in difficult situations. Sometimes for larynx.
Yeah.
Sometimes for this. So let me get some biopsies. See. Across the legs.
There's one question on chat. What is the correlation between histopathologic and radiological depth of imaging?
So on MRI, it is being said that it is around sorry. It is around 95% correlation. Sensitivity is quite high. It is very accurate, and ultrasound is even better. Ultrasound is in nascent stages. Everyone is studying that, but it is considered more accurate than MRI also.
Yeah. Yeah. Right. You is not right. That's about. If there is a lesion in the floor of the mountain, and suppose it is very close to the mandible, abutting the mandible, and oral hygiene is not that great. How will you differentiate in an MRI or in a CT scan that it is an erosion on the bone
Yeah,
because of the disease and not due to any periodontitis or something?
yeah. So that is what that MR image that I showed for the marrow involvement also. So in stir and post contrast, sometimes we may get sorry, overestimation and inflammation and tumor we cannot differentiate. But on T1, we can be sure that this is because of tumor invasion. And it is not inflammatory pathology. It's not too difficult, but MR will be helpful. Erosion, again, if we just have CT, even in erosion, there are certain conditions or certain types of erosion. This SCCs will have like this moth-eaten, like fuzzy erosions. And if there is an inflammatory or there's a caries tooth or something has been removed, that erosion eventually gets corticated. We can see it a little better. So
One MR that time.
but if MR is available, then it's good. Otherwise, I think even clinically, I guess it is also can be estimated. So both in adjunct, we can easily differentiate between them.
We have a problem with the tooth and very soft tooth eroded and lesions around the tooth. But yeah, that's why we have difficulty reading the series which come from outside without the bone input. We always it's almost impossible to reduce.
There's another comment. So someone has just mentioned, thank you, Dr. Kumar. You simplified dynamic anatomy for everyone. Very excited. And we all second that.
Yes.
Thank you. Thank you.
The role of diffusion rate in
Not so. Diffusion obviously is important, but head and neck, we don't use diffusion so much. In lymph nodes, it helps. Again, that is like a completely different conversation because then we'll talk about lymph nodes and ultrasound, CT, PET, CT sensitivity. So MRI diffusion increases the sensitivity of detecting metastatic nodes, but that is usually for metastatic disease. Sometimes when we are thinking about recurrences post-treatment, again, also post-treatment scannings, the anatomy is quite distorted. And in that, if we want to point at a specific lesion, then diffusion may help. May.